Okay, so the same thing here. There's a fair amount of sort of information here about interpreting X-rays, the abdomen. What I think we need to come away from this with is just recognizing an acute abdomen. And there are a couple of really acute emergencies and a lot of stuff that's not so acute. So what can we do to try and pick up on the acute life-threatening types of things that we might need to do? So let's see what we can do here. We'll do the X-ray emergencies management. I think, you know, the same thing, we'll look at a few X-rays, but again, send it, yeah, to have a look. X-ray, especially abdominal X-rays, are really very non-specific, and I think as ultrasound becomes more and more common and more used, that's really where the money is. That's so much better, so much more information that we're going to get, especially for acute care, that I think, you know, at some point we'll be doing ultrasound on transport. Someone will, you know, will get to that.
Just think of
get
the
to that
X-ray
stage.
Tracy and I were looking at, and usually I probably like the A and P X-rays. This was a P and A,
Yeah.
reversed, and it looked like the ribs were broken, and it's like they're all symmetrical, so we know it's not. But it was just the way that it viewed it, not looking at X-rays that much.
Oh, that much,
It's like we're like,
yeah.
you know what, we have to send this and just make sure medical control is fine with this X-ray
See
because
what it is,
yeah.
yeah.
Is there some quantities here?
So, when do we do an X-ray? It's really pretty general. It's really based on a suspicion. If you've got a lot of distension of the abdomen, you're worried about a foreign body, foreign body part's pretty clear cut. But really, if you're worried about obstruction or perforation, sometimes if you're looking for like placement of an NG tube, it can be of help. Some of the other things like masses and organomegaly, bleeding, much less so. As I said, we'll get a lot more info from ultrasound when we can do that more. Let's skip that. So yeah, you can divide the abdomen up into quadrants. I think that's more maybe helpful for palpation, just knowing where the liver and spleen are, and you know, feeling masses like where the colon is, when you might feel stool in the colon gutters, etc. Basic anatomy here. Now, I think there's one where we can see what how rotation looks like. But just look there where you see where all the small bowel is. So just kind of this correlation. You know, the large bowel is kind of wrapped around the edges, and the whole mass in the middle is all this morass of small bowel, bladder at the bottom, and stomach at the top. So it's really just imagining those relationships that can be helpful. IT-free abdo. Identification. What sort of view are you looking at? Technical factors. I'd like to see that the spine is not whited out, that there's enough penetration to see the vertebrae. I'd like to see the fat stripes, this here, or this here, shows that it's good technique and good contrast. You like to see that it's symmetrical, so the wings of the pelvis look the same size, everything's kind of midline. Position, I think this is helpful, just seeing that there's these gutters where fluid tends to collect first, so when you're lying flat, you'll see it on, sort of in in those areas first, and then when it fills up, it'll sort of come over the brim. Probably again more with adults. Sometimes we do this with percussion where you can, you know, and then it goes dull when you get to the side. And then shifting dullness, right, where the area of dullness moves when you move the patient, suggesting that it's, the fluid level has moved. All sorts of bad jokes about shifting dullness, say, when you shift in the chair. Never mind.
When he touches you.
Yeah.
Do I bore you? That's an old one too. So this is kind of uncommon, right? But seeing massive ascites and all that is more kind of an adult thing. But it can be worth, if there's a big distended belly, just percussing it and seeing, is that all air, or does it get dull in the flanks? This is what the stomach looks like. It's nicely outlined with air there in the left upper quadrant. But it's really, really pretty variable. Sometimes you can see organs like the kidney outlined in there. Sometimes you can see the tip of the spleen, but not all that common. These shadows here can be important, the psoas shadows. If you have, let's say, inflammation, you might lose this marking on one side or the other. But these are all subtle things. You can tell certain bowel patterns, whether it's small bowel or large bowel, by the gas patterns. You know, the large bowel with the haustra, which are these transverse markings that you see there. And this is something, again, before ultrasound, and more with adults, you see someone you might think have renal colic, just to see, appreciate where the pelvises of the kidneys are and the ureters. So the ureters run right along the border of the transverse processes of the vertebrae. So if you're looking for stones, you can look down just along there and just by the SI joints to see a little white thing that might be a coup. You make the diagnosis here. There's a, no, I don't think that is, but that's where you would see it. So again, rare to see, but that's where you look for them. SI joints. Yeah, someone had their gallbladder out, so that's eclipse. You can see the lung bases, but psoas edge, talked about that. Kidneys. I don't know, it's just so unreliable. I'm kind of cynical about looking at these x-rays to see any of these things. So if you saw free air in there, like air sitting up under the diaphragm, that'd be useful. If you saw massive loops of bowel, that could be useful. If it's all hazy, like it's full of fluid, that could be useful. But you know, it's pretty non-specific, and again, I don't think any intention to actually interpret abdominal x-ray is be more a waste of time, I think, than anything. But if you did find free air, that's a major coup. So there would be some things that it would certainly be worth, if there's an x-ray, sharing it to get a second opinion on. But what are we looking for acute abdomen that tells us we've got something bad going on as the main problem? So abdominal pain is really common, particularly in kids. It's very non-specific. The usual thing we're trying to rule out is urinary tract infection. Kids will say, my tummy hurts, it hurts here, it hurts there, it hurts everywhere. Probably one of the most useful things is their guarding. So when you gently palpate the abdomen, if you're able to palpate it and it doesn't tense up, then there's not guarding. If it's tense, then that might be much more significant. But so long as it's soft, at least in terms of acute peritonitis, that's a fairly reliable sign that you don't have a problem. The differential is huge, and again, we're not going to try and look through and discover the whole range of things, but the big things that are really going to cause problems are things like intussusception, volvulus malrotation, perhaps trauma. In older kids, although it can happen at any age, appendicitis is the biggie. Occasionally diverticulitis, torsion would be the other emergency, but that should present. Ovarian torsion could be a real challenge, but testicular, usually it's pretty clear where the problem is.
I got a question.
See, it's only the women that laughed at
I know,
me.
I know.
Yeah.
Well, it wasn't
funny
funny,
about that.
it wasn't that, it was
I'm waiting for
Yeah,
the,
nice try, dig out of that hole.
I'm waiting for the demonstration of the walk.
How does the media cause abdominal pain? Or get-
I think
good
it's
question.
just part of just generalized feeling unwell.
Okay.
That it kind of generalizes, and maybe kids can't necessarily, oh, my ear hurts. They're just sick. Maybe they're hyperventilating a bit, they've been crying a lot, they swallow a lot of air, they feel nauseated, they feel unwell, so it's just translated as owie in my tummy.
Okay.
So it just can be quite non-specific. So the danger signs are if you look really sick, increasing pain. So someone who's had a stomachache every week for a month, and it comes and goes, is a lot different than someone who hasn't had any trouble and the pain's getting worse and now it hurts to move around. Bile stained or feculent vomitus, pretty dramatic. Something's obstructed there that's blocking passage. Rebound tenderness, involuntary guarding, that's the sign, as I said, of peritonitis. So it's a matter of how you examine. But you have to be very gentle with your hand. Put your hand on the abdomen and just gently with respirations, let it kind of go in. And if you can get in quite softly like that and you're talking to them and you take it away and nothing happens, that's pretty good. You take it away and they grimace, oh, that hurts. Particularly taking it away, that's the rebound. That's kind of, there's something going on in there. Okay. Marked distension. Often there's a bit of distension, particularly in toddlers, but if it's really distended and tympanitic, that's more concerning. Of course, hemodynamics, instability, significant trauma. The pitfall with trauma is the child abuse scenario where a young child gets punched in the abdomen and they have to do adrenal injury or a pancreatic injury and they don't have a marker. They may not have a lot of distension because it's high obstruction, so the whole bowel doesn't get distended, it's right up here, but they may have intractable vomiting. So it's again, history. Lots of times you don't get any history, just that they're not well. So if there's other suspicions for abuse or trauma, that could be an explanation for the abdominal signs that you see. The signs needing surgery, anything where there's ischemia of the gut. The incarcerated hernia is not very common, but and certainly that would be something that you see, but if you see an inguinal hernia and it's red and hot and tender, that's pretty worrisome. The volvulus will show up more as vomiting, acidosis. So anyone who looks, hypovolemic, acidotic, no good reason why are they so acidotic. Again, this happens much more in adults. They get mesenteric thrombosis and they get infarct their bowel and present with acidosis. But in the odd kid who gets volvulus, kid who's got a GT tube can flip around on that and get a gastric volvulus. That can be quite deadly, particularly because there's a delay in diagnosis of picking it up. So someone, their abdomen looks off, but they got this metabolic acidosis, you know, ding, 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 why is that, what's going on? It can't be just a little dehydration, you know, if it's a severe acidosis. So, transport management, basically stabilize. Analgesic is a good thing because it helps with your, aside from being humane and making them feel more comfortable, it can make it a little easier to examine. And, years ago, it used to be said, you can't give anyone appendicitis morphine because it might mask the signs, you won't tell if they got appendicitis. And that was the teaching for a long time. And then it turned out that, well, that's not true. They started doing it and find it didn't mask all the signs. So it's just again an example of the dogma of one generation. We'll have our own now that we'll see at some point are ridiculous. But so judicious analgesia, controlled pain, the usual supportive therapy for hypervolemia are all kind of important initial management. And if you don't rapidly get better with the initial treatment, then you worry. Right, the abdomen's still really tender, they're still looking hypovolemic, they're still acidotic. Damn, something more sinister is going on. It's not just a little dehydration or gastro.
I think of antibiotics too, a lot of times they'll treat with antibiotics.
Throw in antibiotics, and the probably won't hurt, might help kind of category.
Right.
But again, yeah, if you've got a perforation and peritonitis, then broad spectrum antibiotics would be a good idea to get started. Sure, that's a good point. Yeah, ceftriaxone, sometimes they throw in flagyl as well.
Do we carry?
No,
Yeah.
I think that's fine for
To-
the
for
initial.
the transport
initial kind of
management.
thing, yeah. So again, like with everything, it's a focused history, it's the index of suspicion, something's wrong with the abdomen here. So it's a 12-year-old girl or a female. You think some of the gynecologic things like torsion of the ovarian cyst. It's an infant, the volvulus, where they're really sick, more likely a toddler could have an intussusception that's been missed for, like, they're gonna be okay for 12, 24 hours, but by the time they start passing the current stools, current jelly stools, they're passing that because their gut's got ischemic and it's bleeding. So, you can sometimes feel the mass, but I think it's more just that general pattern of they're sicker and they're not getting better with just the usual supportive things. It says there's something more going on. It's in the belly. We've got to get somewhere. The other thing can be flank tenderness. You always sort of just whack them in the back a bit. Pelvic exams are maybe vanishingly uncommon in our population, of course. But you got to look at the inguinal region and the scrotum. Nothing worse than missing incarcerated hernia. And then other general signs: jaundice, rash, clues to something going on. Henoch-Schönlein purpura has this purpuric rash, which you get vasculitis of the bowel and a lot of pain. So some of those things can be clues to what else is going on. Bowel obstruction usually is fairly sudden. Don't have an appetite. So again, someone's got a good appetite and they're still hungry. Pretty good sign there's not something serious going on. Visible peristalsis, seen loops of bowel, are all kind of pretty hit and miss kinds of things. High-pitched bowel sounds, again, are a useful finding, but nothing alone, like what's high-pitched, what's compared to normal. The presumed etiology is there's a partial obstruction and it's squeezing through a narrowed opening, so the pitch of the sound's higher, but not anything to hang your head on. And then by the time someone's in peritonitis and septic shock, it's usually pretty clear that there's badness going on. one of the things is a malrotation. So some people have a congenital abnormality where the bowel is malrotated. It's not like the normal one on the left here, where the colon is stuck up here. There's this lad's band here, and the colon didn't rotate around to the proper position in utero. And so this bowel here is more prone to twist on itself. So it's just a congenital abnormality that may not ever cause a problem, but it might. Volvulus, twisting of the gut. Again, you know, I don't know that you're gonna see an x-ray that's gonna tell you, but someone's got severe pain, acidosis, not getting better. Gotta get them somewhere. Those that have had previous problems with peritonitis are always at more risk for recurrence. So they can get adhesions, you know, where the things heal with fibrosis and scarring down, and then it traps a loop. Loop gets stuck in a little band or something. So again, the history of previous problems makes more problems more likely.
Alright.
Yeah.
Sorry. Speaking of adhesions and stuff, do you see a lot of repeat or readmissions from old gastroschisis repairs for adhesions and problems?
No, I can't say that I do.
Okay.
Unless it's not to ICU, but then I don't know what happens to the surgical ward.
Okay,
You would think you would, but
one would think it would be acute.
yeah.
Okay, thank you.
Air fluid levels. So you see these straight lines. This isn't an upright x-ray, so that's a fluid level, and that's the air in that loop of bowel. Sorry, I think that's... Hello? Oh, hi.